delegates. Landscape of interventional needed to enhance the lives of those affected. Dr. C.B. Keshavamurthy needed to enhance the lives of those affected. Dr. C.B. Keshavamurthy of Tamil Nadu and performed international public as principal investigator in trials. Sir also support for running this program. Insights and practical wisdom to cardiologist and head of Sir is faculty of Asia Pacific Prevention in Atrial Fibrillation Heart Institute. Publications in reputed journals to his such as stent implantation. Thank you, Dr. Ashwin, Program and Research at CA CTO. Let me have honor to hospitals in Mumbai, Asia Fortis Hospital. Our invitation to Mumbai, Asia Fortis Hospital. Our invitation to present the to have such an remarks and context setting from our present the to have such an remarks and context setting from our on TAVI and plastivity. Second case will be present discussion among the faculty members. Post the discussion of second case, we'll have concluding remarks by our course director. I request audience to post their questions in the comment box so that we can take up those questions in the end. Without further ado, let's embark on this educational voyage together. To you, sir.
Thank you. At the outset, thanks to Emcure for this wonderful program, and it's a great learning experience. Welcome you all to this meeting. It's indeed a series of great cases, and it gives us a great learning everybody to showcase their, not only showcase their skills, but also have a great discussion with wonderful moderators, very learned moderators, learning experience, and take home some definitely good learning points. So without spending much further time, I request now Dr. Srinivas Kudva, who is going to go ahead with his presentation. I think there is a change in his presentation, like from TAVI, we have moved to other things. The second case, when Emcure asked me to present, because the first presentation was TAVI, I also brought a TAVI case. Otherwise, I would have brought OCT case. Yeah, so anyway, we'll have a variety of cases.
Sir, thank you for allowing me to speak. I'm a very junior cardiologist in Bombay, so I'm part of a team that where we do complex cases. Our team has done more than 800 TAVIs here. So I had around 5 cases with me of TAVI with plasty and left main bifurcation. Get my hands on a non-left main bifurcation stenting with OCT, which we had done. So if you're okay with that, I do not subscribe to the notion that there is something called as a type A plasty in cardiology. The minute you let your guard down, that is going to be your downfall. Every case has to be there where you are 100% there in the case without letting your guard down. Every case has to be given its full due. He had a history of an inferior wall ST elevation MI, for which a primary angioplasty was done in the recent past. So if you see here in the circumflex, we've already revascularized his RCA, and he's now having a very classical because he's just 49. If you see here in all the views, the patient does have disease which is there from the proximal, the wires first in the diagonal and in the LAD. We did a pre-dilatation of both vessels, starting with a 2.515 balloon, and we also pre-dilated the LAD. Now we ran an OCT throughout the vessel, which did show what OCT really helped us here was when we managed to come right at the bifurcating. From the angiography, if you were to see, there was circumferential calcium here on the OCT. There was significant calcific lesion which was there. So it had a calcified ostium, which would not have been. After which we decided to do stenting using Culotte. First, we stented the diagonal, and we got a good result. Struts, a dilatation was done to crush the stent, make way. As you can see, then we've deployed the second stent. We're going to do a metal jacket only till where the critical lesion was there. We will do it. The OCT did show us that there was no dissections anywhere. The stent was post-dilated nicely. As you can see, the OCT is also showing the stent is adhered well to the vessel wall. And what was more important was to have a look at the bifurcation. And that is where the OCT really helped us. At the level of the bifurcation, we did a post dilation again with a 312, but at a higher. We also looked at the wire cross, if you can see here, at the level of the D1, just to see how. And what was more interesting to see here, see angiography, it does look pretty beautiful. But when we showed that there was a clear ostium, as you can see, the stent strut is clear of the ostium here. And even in the 3D rendering, you can see that we have managed to clear the stent strut from the ostium, which was there previously. So basically, this case was to actually show the utility of the OCT in the bifurcation. It helped us assess the calcification at the bifurcation. The number of struts at the mouth of the side branch helped us in crossing distal most to the strut. The effect of the kissing balloon on the carina after provisional stenting. I think when any interventionist was to see this kind of a result when it comes to their justice, and when the OCT does show that you manage to clear the ostium also, and the stent is well positioned, I think we feel we've done justice to a young patient there. So I think 49 is still relatively very young for someone to have this kind of disease. Well, I'm still in my learning process. But for Sir, I want Sir's opinion as to what he would say as to how this is.
I now invite Dr. Amitabh to make his comment, especially young individuals. The concept of precision angioplasty has come up now with the use of intracoronary imaging and a very well done bifurcation, I would say.
Yeah, Dr. Goodwar, really well done, and explained all the nuances of bifurcation stenting and all the utilities of OCT, especially if you have OCT, then it really helps you in deciding so many things. The only thing I thought was the lesion was more into after the ostium. So, I mean, we could another depth to that mid portion of the or the proximal portion of the diagonal and try to remain away from the, because after all, although you did it very elegantly, and I'm sure the long-term results will be good, but then in a young patient, if we can avoid is too much metal, I think that's also something that should be thought about. But very nicely done, and especially
my words actually. So the whole idea of asking for non-left main bifurcations was to see what people are doing totally. You just do a drug-eluting balloon where it is necessary, and especially in this Dr. Srinivas case, the side branch was the cost. Otherwise, even medical therapy would be good enough for that, because distal area, if you see after your stent, there is not much of a vessel there. And LAD certainly it required to be stented. It was hemodynamically significant. Use imaging if you want to perfect the result. Do a side branch. If at all there is a completely avoided putting two stents. Because if you see the literature over the period of years, what we have learned is most of the events about six time and effort and money and means of course it's a great learning experience into a diagonal LAD or a circumflex OM. I'll just stop doing it. So even if they are calcified ostia, you use a cutting balloon, you do everything. Finally, you do if you want to do a kissing, you kiss with a drug-eluting balloon on the side branch, and the main branch with a non-compliant balloon. And get out with that. So that is the philosophy with which we invited cases of how people are handling different bifurcations, irrespective of the vessel size. So most of the times, in my mind, it should be a provisional technology, a provisional strategy.
Thank you so much, sir. So, but to be honest, the only reason we did it is because the initial OCT run did show some osteal disease, and we were a good job using imaging. Then why not give the best result? Because patient was young. That was the only reason. Otherwise, we would have.
But Dr. Srinivas, you could have done the same thing that way. So the idea of actually people misunderstand when you talk about bifurcation stenting. It doesn't mean two stents. You need not have dug up so of a two stent case. I'm sure would have so many provisional cases which would have been probably a much more better learning. But it's still not nothing to take away from your case. I think it was beautifully done. But philosophy.
Okay,
Let's
so
start with the
I
original.
have one doubt. So I'm one of the firm believers in nature. So if you were to have um, these kind of lesions where you do have go ahead with bifurcation stenting, or would CABG be the first option? Because I've been trained, even if we have imaging, so I've been blessed enough to train with the best, but we were still told that a CABG is much more a better option. Um, so I wanted to know how it is in Mysore and Delhi.
So again, it all depends. If it's a young fellow like your case, I would really be little. I will think twice before the challenge that you face. हो गया, then you can send to CABG again, because CABG is a final bullet. Like after CABG them and nobody does anything else. But so I think in a center like yours where you have everything available and an expertise like yours, I think you should not shy away from doing a good left main angioplasty, provided the other things are okay. So you should not do it in a very bad calcific lesion, or a lesion was there. Suppose it was a relative LCF lesion, then the way you did it, I think we could have we should have done that. And if there is a Keshav, what is your
I
thought?
completely agree with your approach. I'm hesitant to send such a young patient for CABG so early in life, before the age of 50, 55, maybe 65 years or older, LV dysfunctions, high syntax score. He would go for surgery in our center. And also the other vessel disease like RCA or a PD is graftable. Some large OMs which are graftable, then that would tilt the balance in favor of surgery. Having said that, even in the left main bifurcation of late, if it is a small non-dominant circumflex, I still in my mind I go with a single stent strategy.
Yeah, sure.
A single stent left main to LID crossover if there is an osteal disease. Even in Medina Ven cases, what looks very complex on an angiogram, when you actually approach it, then put a side branch, you dilate it, you put a drug-eluting balloon. If at the end of it you see a decent result, TIMI3 flow, no significant dissection in the circumflex osteum, I have left them alone. And I have followed them up for almost 2 to 3 years now with very good results. So there is no point in complicating things. We have to simplify and get back and take a good look at it. We always have a FFR wire on the circumflex, which helps us really to decide whether it requires a second stent. Like Dr. Amitabh said, if you want to do a subsequent stenting, you can do a reverse culotte or bring a stent from the circumflex into the left leg. So that is my approach, simplifying the angioplasty. The beauty of angioplasty is in its simplicity. Don't put too many stents and try to do too many things. Just leave it at that. Patients will do extremely well. Unless it is a large dominant circumflex, there is no circulation from the right, then you go with a two-stent strategy. LCX has a very complex lesion, osteal calcification, a long lesion in the LCX osteum. Certainly, then you go with a two-stent strategy. My preferred technique for left main bifurcation is culotte. For some reason, I've been doing culotte for a long time, and I think it gives a good result with a good side branch osteal coverage without many crushed stent layers. That is my whole idea of doing it. Very short culotte.
Yeah. And I think if we do the bifurcation using the techniques that you size your stent to the distal vessel, do a good pot, do a good kissing, then many a times, as you said mentioned, so, you may angiographically it may look a little pinch, but if you do a imaging, you see that it's an oval, but the area is okay, and if you do an FFR, it's okay. Then we can leave it. And sometimes, I mean, actually putting an additional stent may be detrimental in such cases, because once you put a metal in the carina and you are there is always some amount of overhanging of the stent struts at the carina, and it invites restenosis.
Also look at the patient profile, high bleeding risk, DAPT non-compliant.
Exactly.
Some patients from rural settings, they don't come for follow-up. In these patients, you put a two stent strategy. It's a big headache for the cardiologist. Patient doesn't realize, he will go away and stop his dual antiplatelet. We keep on thinking what happened to this patient like that. So in such situations, certainly consider provisional even in left main. That was the whole thought process of inviting cases. So, but anyway, nothing to take away from your case. Very beautiful OCT images, very beautiful, nice strategy. And thank you for presenting this case. We'll take any questions from the in the chat box from the audience. Dr. Rishikesh, anything?
Sir, as of now, there are no comments. If there are any, we'll take up at the end.
Okay, so can I start with my case? I'll start with the
Yes, sir.
TAVI. Are you able to see my slides?
Yes, sir. Yes, sir. Sir, please make it full screen.
Just a minute.
Yes.
I just put these together in the last, say, half an hour or
Thank
so.
you, sir.
Afternoon was also busy, and we had some renal artery coil embolization, which suddenly came up after renal biopsy. Patient was bleeding like HB had dropped from morning to evening by some 5 grams or something. So I got busy with that case. So I apologize for the unpreparedness of this case, and some of the slides are very hurriedly made. So this was a case of TAVI, which we did about 2 weeks ago, a very recent case, and the title is very appropriate. I'll tell you why in a short while. This is a 73-year-old gentleman, diabetic, hypertensive, with severe aortic stenosis with a mean gradient of 60 and in NYHA class 4. His list of comorbidities runs several pages. He was a past ischemic heart disease, post-LAD and circumflex stenting with a RCA CTO, which was not attempted because it was thought to be non-dominant and small vessel. He had peripheral arterial disease, and he came back for a peripheral angioplasty to left SFA for a non-healing ulcer, which improved after the stenting, after the angioplasty. He had chronic kidney disease with a progressive increase in serum creatinine, and just before the procedure, his creatinine was 5.2. In fact, the nephrologist said, "Why don't you defer the procedure?" But against all the advice, we took him up because patient had class 4 symptoms, severe LV dysfunction, EF less than 20%, severe mitral regurgitation, recent admission for heart failure. In fact, to do the CT, we had to hospitalize him, give him IV diuretics and some milrinone, and recovered for a couple of days in hospital, and then sent him for a CT. That was his status. And CT was done, and then planned for a high risk TAVI. Such a high risk with a kind of a host of risk factors, and comorbidities were just too many. So we had a detailed counseling session with a video recording with the patient's daughter, son-in-law, and many other relatives, and told them of all the risks. But there are very few options for this patient. There is no, the option was surgery would carry a very prohibitive risk, and surgeons were not willing to take him. So we explained the risk. We also had ECMO on standby. We had PCPS, of course. ECMO was in use in another patient, so we had bypass machine in the cath lab. And I had planned to electively intubate and ventilate it, but our proctor, the god in this case, I would say, Dr. Anantramani, said, "Don't do too many things, don't intubate the patient. Just keep the PCPS machine on standby. We'll do as little as possible, as simple as possible." That was his wonderful approach, which we learned retrospectively, worked out for us in this particular case. So we started off as usual. We put a pacing from the balloon tip pacing catheter from the right internal jugular approach. The problem started here. We took a right axis. Unfortunately, this TAVI CT was done in a center which had just started. This was the first case which they had done the three-mention reconstruction, and they had not taken sections of the femoral artery as much as we want into the thigh. They had stopped just short at the CFA level. So the first shot, we came from the left radial and took a small injection to avoid too much contrast. It showed CFA disease. So we had to abandon the right groin and go on to the left groin. You can see clearly very diseased common femoral artery, which surprised us. So we had to shift to the left groin. This was the left groin. We punctured the fluoro with some ultrasound guidance, and this was okay. Below this, he had a SFA plasty, like I said earlier. Below that, fortunately, up to that point where we wanted the axis, it was okay. So why the slide's not moving? Okay. So this was the first wound angiogram. You can see the calcium. There is some amount of calcium at the annulus, but not too much. There is calcium. This is the stent in the LAD. So till this point, patient was hemodynamically stable with a blood pressure of about 100. And these were the shots. So this was the crossing. Crossing was slightly difficult because the orifice was a little eccentric. So it took some time, but we finally crossed. So that was the wire crossed in. You can see the LV contractility, which looks reasonable till this point in time. Then we put a pigtail and measure the gradients. The mean gradients were about 60. So the 3-Mencio had indicated a 26 millimeter Evolute Pro. Evolute Pro was taken in. So till then, everything was fine. Patient maintained good sinus rhythm, good contractility, blood pressure of about 100, not on any inotropes. So he was doing reasonably okay. Then we crossed the valve. This is the support wire. So the entry was smooth and we brought the valve into position. At this time, the pigtail from the radial artery was entangled with the sheath of the valve. So we had to pull it out and reposition. That took about a few seconds of time because the pigtail wouldn't go back into position. In that time, patient developed a cardiac arrest because the valve was across the aortic annulus, and that much amount of whatever aortic regurgitation or obstruction of the aortic valve orifice, patient had a cardiac arrest. He was resuscitated. We did some CPR, and everything went haywire like it does when patient has a cardiac arrest. So then the valve was placed at about -2 millimeter, and we deployed it. Quickly deployed the valve with CPR in between. Some rhythm has been restored. So we continued with the deployment. So at this point, when we took an injection, we realized that it was too shallow in this particular view. So we quickly recaptured it and then redeployed it again, a little bit lower, about -2 millimeter. Here you can see some standstill, and in between some CPR was going on. By this time, we intubated the patient, started him on some noradrenaline and milrinone. So we went ahead and deployed the valve. This was also very shallow. I think we recaptured it again and pushed it a little bit downwards. Yeah, we have recaptured it. Yeah. And this time we deployed, you can see that the heart is standstill. So it didn't require any pacing because there was no cardiac output. So at this point, I thought we had given up hope, almost some 10-15 minutes of CPR in this after this frame. But Proctor had other ideas. He quickly checked for everything. He checked for coronary occlusion. The right coronary anyway was totally occluded. Left coronary was flowing well. Then we quickly got the echo and saw that there was no pericardial effusion. There was a paravalvular leak from this side where the calcium was there in the annulus. On that side, there was a moderate amount of aortic regurgitation. I would say that was what pushed the patient into a cardiac arrest. So we quickly brought a balloon. You can still see the cardiac standstill. Once we did the post dilatation of the valve with a 21 millimeter balloon based on the annular size, it started contracting. Here you can still see that there is standstill and there is some contrast hanging in the left ventricle, but the valve position seems to be okay. So this is the balloon dilatation. So once we inflated the balloon, the paravalvular regurgitation reduced and continued CPR and some inotropes and adrenaline. Patients slowly regained his rhythm. The QRS, which was wide initially, we thought it is electromechanical dissociation. It came back, then it became a narrow QRS. He had sinus rhythm. He started contracting. Blood pressure came up, and the valve started functioning. So this was a real kind of a nightmarish situation with implantation of the valve in a complete cardiac arrest with no cardiac output. So that was the final position of the valve with some trivial regurgitation. The post-dilatation really helped stabilize the patient. Then he started contracting. We put an IBP also to help support that. So that was the IBP in place. Patient was ventilated for 24 hours. We put a femoral catheter for dialysis. He was dialyzed 2 sittings the same day and the next day. But hemodynamics very rapidly recovered. He came off inotropes and milrinone infusions within 24 hours, and patient was discharged on day 5. At 1 week follow-up, patient is minimally symptomatic. He has single-digit gradients. There is no aortic regurgitation. He had severe MR at baseline, which remained the same, but the ejection fraction, which was less than 20, has improved to 28%, and his serum creatinine has gone below his baseline. His baseline was like 2.5, 2.8, and after the CT, it had gone up, but it came back to about 1.5. So that is the case which I wanted to present today. What a nightmare case. And TAVI is such a wonderful procedure. Even in very critical patients, we have done a case with a valve in a CKD patient with a similar situation with ventricular fibrillation. And valve was placed with ventricular fibrillation, and patient recovered and he was doing well. So the case is now open for discussion and comments by my co-moderators, and any comments from the audience is also welcome.
So very nicely done, Dr. Keshav, and this actually shows the expertise and the experience that you have and your team have, and especially your moderator and everybody. So basically, it's a teamwork, and it's with this expertise that we are now able to take up so many sicker patients who otherwise actually have no hope. So basically, either you leave them to their fate, or you try to do something, and obviously it's a Herculean task to do such cases, but once you do it in a good way, and then the results are also so gratifying that this patient who would have probably not survived a week if nothing was done, and after a week he is with creatinines which are normal, and so it's really a gratifying scenario. So, and these patients, sick patients, even a little bit of AR or something. In fact, doing an angioplasty, we are taking Amplas guide, and we don't realize suddenly we are saying that our patient, why is he going into hypotension? Why is he having bradycardia? And then we realize that the Amplas is sitting into the cusp and causing an AR, and that just by repositioning your guide, you can do. So AR sometimes can be really tricky, and it's so elegantly that you people, and it was really commendable that you even despite such sick patients, you were really diligent to place the device most accurate way as possible, and then so really congratulations and commendable.
Thank you. It was really the Proctor driven. I was in just bystander.
So again, it's a teamwork. I'm sure. I think I believe in the cath lab. Even the GDA is part of the team, and he is also very important. The patient has to pass urine, and if you don't have a GDA, then you have tachycardia, you have all sorts of things. So I think it's a team, and nobody in the team is small or big. Everybody has its role, and if everybody does the role as per the norms, we get good results.
Thank you. Thank you so much. Dr. Srinivas, you have more experience with TAVI. I think this is only our 7th case. We have not done many cases.
I'm part of a team where we have 3 TAVI proctors. So that is why we do a lot of TAVI, but I'm blessed enough to be part of that team. So we've had about 4-5 cases where we put in a stiff wire into the NCC and then deployed the valve because of all these pigtail related issues. That was one thing, because the stiff wire gives you an actual marker as to where it is. So that was one thing which I learned, which was also helpful. I think the most complex case which our team has done was a doctor's mother, and she had SGOT, SGPT of about 800, 900, REAT of 4.5. She had dementia, EF of less than 10%, critical aortic stenosis, LV clot, LA clot, RV clot, RA clot. She was in DIC with platelets of about 40,000 and an INR of 4. So she was airlifted to Bombay here, a doctor's mother, and I still remember we were 5 of us in the room, and we were telling them that 99.99999% this patient is going to die. And the doctor was like, I agree, she's my mother. Even if there's a 0.0001%, we want to try. So this is about 3.5 years back when we had done this. And that time we did a balloon expandable valve, and we did over the wire pacing because of the RA-RV clot.
Yes.
And the LV was also 10%, RV was also down. So we put in a stiff wire in the LV. We used alligator clips, and we did over the wire pacing. We used a balloon expandable valve, just one shot. And with God's grace, she did well. In a week, the LFTs came down. Creat, which was 4.5, came down to 1.6, 1.8. LFTs were bang normal later on. LV improved to 40%. Her dementia reversed, which was because of hyperperfusion. And that was the beauty of it. Like, the doctor got his mother back, means not physically, but even mentally, she was back. I think that was the most gratifying case our team has done. So the DIC reversed, everything reversed. It just showed us the beauty of TAVI was something. So I think beautiful.
Yeah. Can't imagine sometimes how patients recover after that.
So the unfortunate part is that many of these patients they are suffering for years together, and they are not. And like in your case, I'm sure if it's a doctor's mother, then I mean, unfortunately, she was led to a stage where she was almost dying. So had it been done a little earlier, probably it would have been more easier. But then really nice. But I think the awareness also needs to be increased, and especially now with TAVI, which is now available to. Only thing is the finance is definitely a challenge for many people, but still, the fear of surgery is at least allayed, and finance also. I think again, it's a matter of mindset. People are walking around in 20 lakh, 30 lakh, 40 lakh cars on the roads. So I'm sure for your own mother, or for your own self, you can spend that much money. But I think the mindset should change.
Yeah, absolutely. Thank you all for the wonderful comments, and thanks, Dr. Srinivas Kodua, for sharing that case history. Any comments in the chat box, Dr. Rishike?
Let me check. So there are no comments in the chat box. So
Okay.
I just request you to reflect on the valuable insights we have gained today and give your concluding remarks.
Yeah, we have seen two wonderful presentations today by Dr. Srinivas. That was a great learning experience that he shared his two cases, and the TAVI case which I showed. I am sure it will be interesting and have a few learning points for all the people in the audience. And special thanks to my co-moderator, Dr. Amitabh, for the very mature and expert comments. And thank you all, and thanks to Emcure as a team. And we'll continue to do this program in service for all the young interventional cardiologists to present their cases and have a great learning experience. Thanks again.
Thank you.
So
Thank you,
we are
Dr.
near.
Keshav, and thank you, Emcure.
Yeah. So we are nearly at the finish line. But before we conclude, let's express our gratitude to all who made this scientific program possible. I would like to express my sincere gratitude to our esteemed course director, Dr. C.B. Keshamurthy sir, and our distinguished moderator, Dr. Amitabh Yaduvanshi sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Srinivas Kudva sir and Dr. C.B. Keshamurthy sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for this no thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to sales, marketing and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you. See you all.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thank you for joining. Good night.
Good night.